Right. Good afternoon, everybody. Oh, yeah, one more person. Good afternoon. So thank you for joining us on this discussion around suicide and COVID-19 pandemic, understanding Canadian stories. My name is Shauna, and I work for Nova Scotia Health in mental health and addictions on an initiative called Roots of Hope, which is about building capacity in our communities to support those that are thinking about suicide and or grieving from suicide. It's part of the Mental Health Commission's work, and one of the pillars we work under is research. And this afternoon is about providing an opportunity for Nova Scotians to learn a little bit more about research that's happening in suicide in Canada. And in this case, an opportunity to participate if that feels right for folks and to learn how to go about participating in this research. So thank you for joining everybody today. As we're talking about suicide and suicide-related topics, just be sure to take care of yourselves through this. It's not necessary to have your cameras on by any means. Feel free to take breaks as needed. We'll be focusing largely on this conversation around this research. So there won't be any opportunity to share personal stories or anything like that from our participants today. But this lands differently for different folks, so please take care of yourself as you need to. And pleased to introduce Dr. Juveria Zaheer and Eleanor Lamb, who will be leading this discussion. So I'm going to take the spotlight off myself and give an opportunity for Dr. Zaheer and Eleanor to introduce themselves.
Thank you so much. And I know that it's the summer and it's a busy time for folks, and we're so grateful for your time. My name is Juveria Zaheer. I'm a psychiatrist and I work with Eleanor and Elisa. I'm the medical head of the CAMH Emergency Department here in Toronto, and our team does research on suicide and suicide prevention, focused on empowering people and allowing them to tell their stories in a way where we can create solutions that work for the folks who are actually experiencing distress and suicidality, as well as their families and their supports, and often their care teams, people like you. And so our goal today then is to speak to you a little bit about the work that we're doing, so you can so we can share that work if it may be relevant and interesting for you, and then also to get your support in terms of supporting our last push of recruitment, which is for older adults whose voices are so important in suicide prevention. So that's me, and I'll pass it along to Eleanor to introduce herself.
Hi everyone. So I'm Eleanor and I'm a master's student that's under the University of Toronto Institute of Medical Science. And I'm supervised by Dr. Juveria Zaheer and Dr. Isra Hussein, where I worked in, Juveria has a bigger project that we'll introduce to everyone. And I worked mainly focusing on the older adults population, looking into the suicidality during COVID and how they recover, and also some of what are the factors leading to it and things like that. So I'll be sharing my screen, and then maybe Juveria can start with the background and everything.
Thank you so much, Eleanor.
Okay, so are you able to see like the first slide?
Perfect. Thank you so much. And we can advance.
Okay.
There's a lot of information here, but we promise there'll be lots of time for discussion as well. Next slide. So I think all of us remember where we were, 5.5 years ago when the pandemic began, and it was, I think, a very stressful and traumatic time for every Canadian in different ways. And I think one of the initial worries is that when we thought about the pandemic, people were thinking, well, one of the worries is that a lot of the things that are risk factors for suicide are also things that can happen more often in a pandemic. So for example, people with mental illness may not be able to access care in the same way. So if, how do people admitted to hospital? How do they go to an emergency department? How do they see their outpatient services? And so the question began, are for folks who already have pre-existing mental illness or are developing mental illness, are they going to get adequate care? And could that be potentially a risk? The other piece is that for people who have already experienced suicidality, those folks tend to get worse care overall in general in the mental health system in Canada and across the world. And so how are we going to support those folks in a pandemic where resources are scarce to begin with? And then there's other pieces that were worrisome. So one is, in the pandemic, as we remember, many people face financial stressors. So being furloughed from work, higher costs at home, not being able to meet their financial needs. Also, we know that domestic violence is an interesting term. We can also call it intimate partner violence or violence that occurs on inside of a home. We know, speaking to people, it's just harder to leave the house. So when 4 or 5 people are stuck in a house together, if there is violence or stress in the home, things can really exacerbate. And that's something that I know that we saw a lot in our emergency department. Older adults can be especially vulnerable here, as well as people having to return home, like students, university students, or young people who may have moved out, having to be moved back into places that aren't safe for them, and feeling trapped. Alcohol consumption, we know that in Ontario, where I'm from, I'm not sure about the data in Nova Scotia, but alcohol consumption rates went up by about 20% across the population in the first few months of the pandemic. We know that people are experiencing isolation and trauma, loneliness, and bereavement, and especially thinking about older adults. I know my grandparents, I remember I'm lucky enough to still have both grandparents on my mom's side saying, how can we live like this if it means like not seeing our grandkids? Like everyone's trying to keep us safe, but we can't see anybody, or we can't, leave the place where we're living. Is very, very stressful for folks. And then of course, the loneliness becomes work, feeling trapped, and then bereavement. Many people lost people they love. There were so many deaths and challenges and awful things that happen, and that can be a risk factor for suicide as well. Access to means is an interesting point. So I remember early in the pandemic, and I think it made sense, right? As a physician, I would certainly, pharmacists are prescribing larger amounts of medication, so people don't have to go to the pharmacy that often. So people who had daily dispense may not have that anymore. People may be getting 3 months worth at a time, which is a risk. And we also know that in some places, not necessarily in Canada, but I know in the US, gun ownership went up, and we know that having a gun in the home is a risk factor for suicidality independent of anything else. And then, worries about irresponsible media reporting. There were a lot of stories early on that suicide rates were definitely going to go up, and really dramatic and traumatic stories about healthcare providers, for example, dying by suicide. And when we talk about suicide as something that's inevitable, it can really cause increased rates of suicide in the population. Next slide. And so what have the data shown? So as we said, there's this really strong concern about an increase in suicide risk related to these risk factors that we know are related to suicide. But early on in the pandemic, suicide rates were found to be relatively stable across several countries, but there was more distress. So in survey data, people were endorsing more suicidality, more distress, and there was increasing calls to distress lines here in Canada, and increased rates of suicide in some specific early groups that we identified. And really interestingly, in Hong Kong during SARS, which was the last pandemic we remember before this in 2003, the biggest increase in suicide rates were actually in adults over 65, and I think that was a really important finding during that pandemic. Next slide. Oh, sorry. And so, to better understand what was happening, I think we can make lots of assumptions. Data only tells us part of the story, it tells us what's happening, but doesn't tell us why. So we were able to apply for funding to look at Canadian stories across 4 provinces during this COVID-19 pandemic. Next slide. So we really have a big team. We have collaborators in Nova Scotia, in Manitoba, in British Columbia, and in Ontario. Of course, it would be better to have representation from all provinces and territories, but this was a pre-existing research network that we had established that we wanted to leverage. We also have really important groups involved, like Talk Suicide. The medical director is involved here, the Canadian Centre for Suicide Prevention. We have geriatric psychiatrists on the team, which is really important to understand the experiences of older adults. And most importantly, we have people with lived experience as full and equal members of the study team, because I don't think you want to create questionnaires or do interviews without understanding people's experiences and making sure that it is actually what people with lived experience think is important. Next slide. Next slide. And so we know that in the pandemic, it had a disproportionate impact on people with mental illness, worsening mental health, substance use, poorer access to care. And we also know that people were having huge, broad economic, social, and health systems disruptions. And so we wanted to understand the experiences of Canadians at risk for suicide to help develop evidence-informed practices and policies, and to figure out what people need, when they need it, and how we can deliver it. Next slide. And so we were going to interview and have interviewed about, I think Elisa can correct me, but I think about 80 so far, maybe a little bit more than that, of Canadians with suicidality by doing in-depth qualitative interviews across 4 provinces. And these are the research areas that we're really interested in. Next slide. And this is our provinces and our sampling, and we just want to get a nice broad sample across the province. Because we're in Ontario, it tends to be a little bit easier to recruit here because people know us and they kind of know our team and they feel comfortable saying to people that they work with, like their patients, hey, this is a great study, you might be interested. And so we're working hard to do things like this to get to know you better, so if you have a client who had suicidality during the pandemic, to be able to see us and say, yeah, they're nice, they're going to listen to your whole story. It's not going to just be stressful or them asking about very specific things. We let people tell their whole life story. And I think our experience is that people find this to be very therapeutic. We don't often talk about what it felt like during the pandemic, and so most of our responses, I think almost all, sort of reflect on the fact that it's a really, really positive and empowering experience. And there's also, of course, an honorarium associated with it that we would send them, and everything can be done virtually as well. Next slide. So we want to make sure we recruit people who are at elevated risk for suicide, and that includes older adults. One of the challenges is that older adults tend to be a little bit more difficult to reach through kind of the internet or through other kinds of like social media type of pieces, and they may be a little bit less comfortable with like things like a Zoom interview, or a WebEx interview, and so that's been a challenging group to recruit. Next slide. And I'll turn it over to Eleanor.
Yeah, so as Juveria mentioned, older adults are a little bit harder to recruit for us right now. So they're kind of underrepresented in the interviews that we have right now. And so it's very important for us to really understand what's happening for them during the pandemic. And why does this really matter to look into suicidality in older adults? Is because suicide rates actually really increases with age in many countries, including in Canada, with the highest rate among men aged 85 and older. And also, older adults are more vulnerable to fatal suicide attempts due to greater intent and also the use of highly lethal methods. And during the pandemic, they're very vulnerable in the sense that because they have like higher risk of severe illness and death from COVID, and also they're strongly encouraged to isolate. And so, different papers they actually talked about increased risk factors worsening during the pandemic. So these risk factors has been identified. For quite a long time for the older adult population, which includes social isolation and loneliness, which are some of the risk factors that has been identified for like a long time. And during the pandemic, it showed that older adults they did experience like increased social isolation and loneliness, as well as grief, loss of loved ones, bereavement. These are some of the I think most of them they do increase like during the pandemic with some of the papers talking about which kind of might increase the risk of suicidal thoughts and also self-harm and also crisis episodes. As well as disrupted care, many of them they do experience limited access to mental health and physical care. And Many of them also reported some of the mental health conditions worsened or resurfaced like during the pandemic, including increased depression, anxiety, as well as cognitive decline. And that's why we really wanted to include more older adults in our study to really understand the whole picture of what's really happening and to see how we can really support them, and how do we maybe what are some of the suicide prevention strategies for this population, and how do we support them in the future?
So I won't bore you with this stuff. It's just sort of ways just to make sure that the work is scientifically rigorous, and we're really thrilled to answer any questions about it. But it's a little bit methodsy, cannot be a little bit less interesting. But we want to make sure that our sample looks like Canada, so urban and rural, equal representation from various age groups. We want folks who've had suicidal ideation, but also have had suicidal related behaviors, because sometimes the groups are similar, but sometimes they can be different. So sort of a broad spectrum of folks. We want people that represent the diversity of Canada in terms of ethnicity, and we want gender diversity as well. So women tend to be much easier to recruit in studies like this, and which I think people can identify with. Women tend to be a little bit more socialized to be able to express emotions, tell stories, and men are struggling as well, but may not have that sort of same facility or comfort sharing their stories. And so, we wanted to make sure it was balanced in terms of men and women, and also including trans and non-binary folks as well, to make sure that we were inclusive and understanding their experiences as well. And we also want to make sure that we get folks who have a variety of socioeconomic status as well. So as one of our respondents said, it's very different to isolate when you are in a beautiful cottage with two or three people in it where everyone has their own room and office, or you're six people in an apartment in an urban center trying to, with two bedrooms. Like, these are very different. As well as the experiences of someone who has schizophrenia is going to be different than the experience of someone who has anxiety. So we want to make sure that we have a variety of statuses around diagnosis. And then also, we all know that people with pre-existing medical comorbidities, it was extraordinarily stressful because we would hear the news that, well, if you have medical comorbidity, you are at higher risk, and that can be very frightening. So we wanted to get a variety of representation of different kinds of health status as well. Next slide. And we've recruited through all kinds of ways, because we want to get people, if we only recruit in a hospital, we may only get people who are getting psychiatric care or who are admitted to hospital. If we only recruit on social media, we may only be getting young folks or people who have suicidal ideation rather than behavior. So we wanted to recruit across a broad variety of settings. So we have, outpatient clinics, urgent care clinics, social media, research registries, and then we start off general, like everybody, and that's how we got so many people. But then also trying to do targeted recruitment. So, Nova Scotia is a place, even if you don't have someone who's over 65, if you have anybody with suicidality, we're hoping to bump up our Nova Scotia numbers, because I think, I'm a Newfoundlander. Like, I think culture is different across different provinces, and it's not fair to only have representation from one set of folks. And then also, rules were different in the Atlantic bubble, and I think we want to make sure we have lots of people's experiences being captured. So right now we're really focused on targeted recruitment in Nova Scotia in general for everybody, as well as older adults across the country, and in Nova Scotia particularly. Next slide. And this is just for if you would like to, people can refer themselves. So if you put a flyer up in your setting, or send out the flyer, people can connect with Elisa, and she takes care of everything. And that it's a matter of giving her a phone call, which can be stressful for folks, but that's one way. And the other is if you're working with someone who you remember, like, oh, they were really struggling in the pandemic, they may really benefit from telling your story, you can give them the information sheet and they can contact us. Or we have a very short little consent to contact sheet where they can sign it. You put their name and contact info, and then just flip it to Elisa, who will contact the person. So it's just like one less step for them, and it can feel a little bit less scary for the patient or participant. Next slide. And here's our example of this approach in Nova Scotia. So we have ethics approval to have clinical recruitment, and we also have a study safety resource sheet and centralized study safety support. So in general, we measure people's suicidality before and after the interview. I think talking about what's happened to them tends to reduce suicidality, if any exists, and tends to be experienced very positively, but we take care of all of that safety piece. We've done targeted social media recruitment, recruitment in clinical settings, recruitment by clinicians, and we have on our advisory council several folks who are from Nova Scotia or practice or work in Nova Scotia, including Veronica, who works with Indigenous communities in Nova Scotia. She's really wonderful, and some other members of our team from Nova Scotia who can bring that perspective as well. Next slide. And I'll skip over this, but this is just kind of what Elisa does to get people ready to participate. But it can be done over the phone if people aren't super comfortable answering a bunch of questions in like a survey on the internet, because that can be stressful for folks who are older. Elisa can do everything by the phone, and the interview can be done by usually it's done by WebEx, but we've done some by phone as well. So if people are more comfortable just talking on the phone, we can do that, no problem. Next slide. And then we have our lab has done a lot of suicide research, a lot of qualitative suicide research. So we have a lot of expertise in this area, making sure that we keep folks safe. In the hundreds of interviews that we've done over various studies, we've never had to call police or never had to worry about someone's safety. We have all of this stuff really built in, and it runs very smoothly. Next slide. And there's a psychiatrist on call at all times. So if Elisa's doing an interview, or Eleanor's doing an interview, and the person's like, I don't feel safe, there's a psychiatrist immediately available to speak to them. It's 99% of the time it's me. And then if I'm away, we have some really, really excellent colleagues who take that role on, who are really trained in acute care, really empathic and really supportive. And in one of our pilot studies, we only had the experience once where I didn't start an interview because the person was too distressed. So we moved into safety mode and were able to still make sure that they got their honorarium, provide lots of support, provide resources. But that was the only time that's happened across several studies and hundreds of interviews. Next slide. So it's a phone or video conference. I imagine older adults often prefer phone than having to like navigate WebEx and the link. Sometimes it's hard for all of us. It's about 30 to 90 minutes, and it's really nice. It's like not meant to be scary. Basically, we like to get to know you better. We like to hear a little bit about what your life was like in general growing up before the pandemic, any experiences of healthcare, what helps, and then we ask people about what they remember of the pandemic. And we know that as the pandemic is further in the rear view, although still people are still getting COVID and it's still an issue, it can be hard to remember the exact details. And we don't mind if people don't remember exact details and dates. It's more about their feelings and thoughts and perspectives. Next time, our early findings. Yeah, so this is just, I won't belabor this. We've interviewed about 89 people, and you can see our breakdown here, and you can see the place where we really want to focus is over 65 and Nova Scotia. So both and. Next slide. And so here's who we're looking for. And so if you, a few things that would be super helpful for us, only if you're interested and you think it would be helpful for your setting, we can send a flyer for you to put up in your setting. So if people that are interested can contact Elisa. We can also send you consent to contact forms and our information. So if you have a client who you think could benefit from participating or may be interested, it's about 2 hours total of commitment, the kind of preliminary assessment plus the qualitative interview. And I think the honorary is $40, Elisa, if I'm not mistaken, which is sent to them in the mail by check or direct deposit now, I think, are the two options. If you have anyone who might be interested, you can either let them know by giving them Elisa's contact, or you can get their name and have them sign our little form, and then Elisa can be in touch with them. I know that everybody here is extremely busy, and we're so grateful for your time, and we know it might not always be possible, but it would make a huge difference for us and a huge difference in getting this work published, and a huge difference in Eleanor's thesis becoming completed, and really sharing some valuable information that I think can help people moving forward. Next slide. And here's the flyer that we can send you. If you're interested, we can send you like a laminated copy to post, as well as paper copies, as well as consent to contact forms. Maybe we can disseminate those after the interview to folks, after the session to folks. Next slide. Okay, perfect.